Good morning, good afternoon, and good evening to everyone in the call. Happy to see friends, familiar names in the roster tonight, and also new names. So welcome to our AHIN Hour. This was a long time coming when we had our planning meeting way back, I think in January or February of this year. I had Steven and Dr. Herman Tolentino going through a brainstorming activity on how we can strengthen the Asia and the African network. And we agreed that the first topic would be just understanding what are the different ecosystems in the various continents in the world. Unfortunately, we could not invite the South American region represented by Rica Insa because of the difficulties in the time zones. But there is also a network, an e-health network in South America called Rica Insa. I'm Dr. Alvin Marcelo. I'm the member of the governing committee and also the treasurer of the Asia e-health information network. So we are a network of digital health advocates from government, academe, non-government organization, and private sector. And we are a collaboration of digital health advocates. We were created in 2011 by the World Health Organization to help ourselves and our neighbors, our neighboring Asian countries with our respective digital health development. So we started with 7 people from 6 countries. We convened in Bangkok, December of 2011, and exchanged ideas on how we can strengthen the network so that we can learn faster through the peer learning approach. And today, as I speak, we now have more than 1,800 members in more than 20 countries. Our structure right now is more complex than this, but this is as simple as I could show tonight. At the top would be the General Assembly or the network or the members of the network. And membership is free right now. If you are interested in joining the network, just send us an email or go to the ahin.org website and click the join button. And our webmaster, Charis, will help you out in the membership process. And then we ask for volunteers from each country, at least 2, one from government and one from civil society. If there are 2 volunteers from government, then we would accept those representatives. And on the right would be the countries that have representatives into the Working Council. The Working Council is our sounding board. If there are ideas that we'd like to vet, and if we are going to ask for strategies and directions, we consult the Working Council. And then there's a governing committee, which I will show later on in the next slide. And then we created subgroups within the network. One group is working on research. Another group is working on interoperability labs. That's the COIL, or the Community of Interoperability Labs. Another group is working on enterprise architecture. And one group is called the Standards and Interoperability Lab Asia, which is now based in Thailand. And then we are supported by a group of very energetic secretariat in Manila, Kuala Lumpur, Bangkok, and now Jakarta. Dr. Bunchay Kichanayotin is our chair. He is from Bangkok, Thailand. Dr. Fazila Alauddin is a board member. She is with the MOH Malaysia. Anis Fuad is with the University of Gadjah Mada in Indonesia. And right now, our executive director is Mr. Jai Ganesh, based in India. Over the past 10 years, since 2011, 2012, when we started meeting annually in our general meetings and then in our side meetings, we realized that countries are often in the same boat when it comes to their digital health challenges. And in the 10 years of learning from each other, we discovered that national healthcare IT systems are very complex. And to succeed, countries need to work on their 4 important fundamental topics, which we summarized as the gaps: the governance, the architecture, the people and the program management, and the standards and interoperability. So this was our first general meeting in Bangkok, Thailand, hosted by Dr. Bunchai. The second one was in Manila, as well as the third one, which was at the Asian Development Bank. This is the fourth one in Bali, Indonesia, hosted by the Ministry of Health Indonesia and the BPJS, or their National Health Insurance Agency. And this one was the fifth one in Naypyidaw, hosted by the Ministry of Health, Myanmar. Our sixth and the most recent face-to-face was 2018 with the Ministry of Health, Sri Lanka, and with the Health Informatics Society of Sri Lanka, helping us co-host this in Colombo. And then, of course, the pandemic happened and we had to conduct our next two general meetings online. But this year, November, we will have our, we had our face-to-face meeting after the pandemic last year in Manila, October. And this year, in November, we will have our general meeting in Jakarta, again, co-hosted by the Ministry of Health Indonesia and BPJS. So on the screen right now is an ecosystem. And I'm sure that if we spend some time with pen and paper and start drawing out the circles and the boxes and the lines of the stakeholders within each country, in the call right now, we would have almost similar ecosystems, a lot of stakeholders, many lines or transactions connecting stakeholders to each other. And I would guess that we would even have different rules and contractual arrangements with each other. And I think that's the reason why the health sector is one of the difficult sectors to digitize. It's because the standards are very difficult to set out, and generally because of the number of stakeholders that you need to consult and who need to agree. And definitely government plays a big role in getting the stakeholders together. And that's why our Mind the Gaps and Fill the Gaps framework starts with governance. This is an internal ecosystem that we've created over the past 10 years. As I mentioned, we have the AHIN Working Council at the top, where we consult and vet our strategies and our ideas. And over the past 10 years, we've formed two main groups in AHIN. One of them were the ones who took the certification course on the Open Group Architecture Framework, or TOGAF. And they formed the Regional Enterprise Architecture Council for Health. So basically, we consult these AHIN members who have undertaken and passed and got certified in the Open Group Architecture Framework when it comes to questions about architecture. And we have in the call as well some of our consultants and our advisors in the Regional Enterprise Architecture Council for Health. On the other hand, we also have research units and sometimes IT units inside the Ministries of Health that have formed interoperability laboratories within countries. This came about way back in 2015 when there was an AHIN meeting, and the participants in the meeting said, why don't we set up an interoperability lab in each country so that we can understand how this interoperability animal works, or how it sounds, how it moves. So together, about 6 to 8 countries volunteered and said, okay, we'll start setting up capabilities for interoperability labs. And in succession, Dr. Bunchai and I separately, we visited the Mohawk Lab in Hamilton, Canada, and we saw an example of how an interoperability lab works. And thanks to Derek Ritz for organizing that, we had a view of what an interoperability lab can do for the community that it serves. And so the reach and the coil are actually complementary to each other, where the reach come up with artifacts or designs. The community of interoperability labs are the ones who implement and build these artifacts. And we have advisors from OpenHIE, we have advisors from HL7 Fire, from PATH, and the interaction between architecture and the actual construction is very interesting, because when you have that ecosystem in place, then you start understanding that this interoperability thing is actually hard. And the only way we can solve this interoperability problem is if we talk to each other and make sure that we have an ecosystem and that we are helping each other. So when we released our call to action about our mind the gaps and fill the gaps for the architecture, our call to action was for every country to identify an internal enterprise architect within their Ministry of Health. But at the same time, they should avail of services from external professional architectural firms or individuals to help them out with their architectural work. So an internal person and an external expert. And then both of these people, we asked them to be nominated to the Regional Enterprise Architecture Council for Health. On the right side, our call to action is for every country to set up at least one interoperability lab in the country. And for this interoperability lab to serve the interoperability needs or the use cases of their ministries of health. So I hope that by November, we would have some very concrete sponsorship statements coming from specific ministries. I won't name them right now, but we're working on getting official and formal sponsorships of ministries of health to these interoperability labs. And some of them are listed at the bottom. In the Philippines, we have the CILAB at the University of the Philippines, Manila. There are labs in India, in Thailand, Vietnam, Laos, Taiwan, and Sri Lanka. We have a regional lab, which is the exemplar of all of these labs, called the Standards and Interoperability Lab Asia, which is now based in the Standards and Interoperability Lab, Thailand. So a disclaimer that the next slide will be full of logos. It doesn't mean that we have a formal relationship. AHIN has a formal relationship with all of them, but definitely they are in our radar screen as important partners in the ecosystem. Another disclaimer that I may have missed a logo of a partner, but let me go to the next slide and let's see what I have. So I divided the ecosystem in the Asia Pacific into types of sectors. So there's the governments, of course, who represent the people and the citizens of their country. And then we have the UN agencies. In Asia, I guess they have divided it into two parts, the Western Pacific region and the Southeast Asia Regional Office, WIPRO, and CRO. The Pacific Island countries are part of the Western Pacific region. There's UNICEF. There's UNICEF, the Program on Digital Health Center of Excellence in UNICEF called DICE. There's ITU, and there's the Digital Impact Alliance. So these UN agencies, they convene governments and they talk about best practice, they talk about strategies and directions. And I think these are very important partners in the digital health ecosystem. They have the what I call the pulling power, or the ability to convene and get important decision makers around the table and talk about issues and possible solutions, and definitely collaborations and shared solutions to their common problems. In the middle are the networks. I deliberately put them in the networks. So these are AHIN. You'll hear more about Helena later on from Steven. There's actually a Pacific Health Information Network, or PHIN, for the Pacific Island countries. And I already mentioned about RECA-INSA. I know that I was not able to capture all of the networks, but these are the networks that right now are actively interacting with AHIN. On the academic side, and we have a lot of these in AHIN, of course, there's the University of the Philippines, Manila, which served as the secretariat of AHIN during the first 4 years that AHIN was still an informal organization. We have the University of Gadjah Mada that has helped us organize events in Jakarta and in Bali. There's Kathmandu University, Tribhuvan University that have helped us with our Open IMIS community of practice, very active in the Open EMIS community of practice. And then we have the Health Informatics Society of Sri Lanka and MIT Critical Data. Again, we have a longer list of academic partners for purposes of just identifying the different types of sectors in the digital health ecosystem. I just put this few examples on the screen. And then for our development partners, we've received support from Patrick McGovern, Path, Digital Square, GIZ, Fundación Pierre Fabre, the Global Fund, USAID, Transform Health, World Bank, and ADB. Again, not a very exhaustive list. But what I wanted to really just show would be the role of the networks as the glue or the bridge between this government and multilateral organizations that work within a certain set of rules and protocols. And on the other side would be the civil society composed of non-government organizations with academia and development partners. And the networks are, I think, they become the interoperability layer, so to speak, when it comes to getting all of the stakeholders together, bringing them into the meeting, and creating a conducive, collaborative environment so that ideas will come out. There will be friendly debate. There will be arguments, definitely, but also ending with agreements and common ways of moving forward. And to me, this is what AHIN has been all about in the past 11 years, that we are able to pull in our friends, our partners into meetings. And during these meetings, and you should join some of these meetings, a lot of ideas come out. Some of them are out of this world. Some of them are very exciting. And it just helps to have kindred spirits and people in the same set of problems, faced with the same set of problems and trying to find common solutions to their problems. It's very interesting to get them and see them collaborate in one place. And so I'd like to end my part just to share some of the ecosystem best practice and lessons learned that we've experienced in AHIN. It always helps to start with shared principles. Actually, we do have shared principles. We want health for all. We want universal health coverage. We want to use technology responsibly. We want to be ethical. And it's always good when you reach out to a partner or when a partner reaches out to you that you agree first on the shared principles. And it's very easy, but it always works well if this is the first thing that is put on the table. It also helps if we all understand that we all have an agenda. I have an agenda. The University of the Philippines has an agenda. AHIN has an agenda. All of the partners, all of the UN agencies, they have agendas, and I think it's fine. It's what makes people tick. It's what makes you join this webinar. You need to have an agenda because you need to have that to get going, so to speak. But this alignment of agenda is what we found to be very effective. If we can find this alignment, and I learned this from Dr. Bunchay, our adjourned or mentor in AHIN, this alignment is very important because once you find it, the synergies will immediately follow. And these synergies are the efforts, the energies that the different partners bring to the table. And suddenly, because of the things that they put together on the table, you are able to achieve greater things as compared to something that you will achieve if you were working alone and not together with your partners. Fourth, funding is important, definitely, but not always necessary. There are partners that have very strong alignment with what you do, what you need, and they have their own resources. If they're willing to align with you and share their non-monetary resources, I suggest you take it. Both of you will go a long way by sharing the non-monetary, non-financial resources that you have. Of course, no one is perfect. At some point, there will be friction, there will be debates, there will be arguments, there will be misinterpretations. We're all human. All our organizations are made up of people. People make mistakes. No one is perfect. But if the alignment and if the agenda and the principles are agreed upon at the beginning, these mistakes and these mishaps can be forgiven, and we can come back together as partners again, as friends again, and continue to pursue our shared vision and principles. And then keep the fire burning, but don't burn your bridges. Sometimes you will feel like it's very tiring. There's a lot of work ahead and not a lot of people that you can pull in to help you out with what you need to do. It's okay. Everyone is in the same situation, but don't lose heart, and call upon your friends. That's why we have AHIN. We're actually a group of friends that are interested in improving the digital health implementation in our respective countries, and we decided to just help each other. And always say hello once in a while. You might have in your mailing list somebody that you've not said hello in the network. It always helps, at least for me personally, to send an email to them individually once in a while. I see some of them in the call, so I guess my hello worked because they are now in the call listening to our webinar tonight. So thank you, and I'll pass the floor now to Stephen. I'll be back for the Q&A.
Hello, everyone. My name is Stephen Wanye. I'm the president-elect for HELINA. HELINA is the Pan-African Health Informatics Association. It's basically a network organization, as Dr. Alvin has mentioned. We are the Africa chapter of the International Medical Informatics Association, and working quite closely with other organizations in Africa and also outside Africa to strengthen the health ecosystem across the continent through digital health and also health data as well. So I'm going to go really quickly through HELINA, just because I'm here wearing my hat as the incoming president for HELINA. So HELINA exists to promote education research in health informatics in Africa, and we also are very keen and committed to promoting and supporting ethical implementation of modern and evidence-based health informatics. Lastly, we also on this very aggressive journey to professionalize health informatics in Africa. And the reason I put that there is because health informatics in many African countries is not a recognized profession, especially in government. We don't even have formal roles called, digital health officer, with the exception of Rwanda, which is one of the first countries, and really congratulations to them. But you're working with other African countries to start recognize health informaticians as a formal role and as a cadre of staff in their scheme of service. So that's why that third bullet is so important to us. And we think this is really what will change health informatics and digital health in the world, is just by having a very critical mass of trained, experienced health informaticians. So that's who we are in terms of our vision. We exist to advance healthcare through evidence-based health informatics research science, developing that into interventions and applications, and implementing that effectively and responsibly, and of course, educating our masses. A couple of our core values, not surprising, want to be relevant, we ensure that we are accountable, especially to the people who end up using these digital health interventions. We hold a high level of integrity and ensure that we are transparent emotionally. So like every organization, we've got an organogram. That's how we look like. We've got a general assembly at the top that basically comprises of member associations. Currently, we're about 12 in the continent, and we are rapidly expanding. That's where we draw apart from, and the strength of the network association. Got a couple of priority areas which are very similar to what Alvin shared for AHIN. On interoperability, looking at standards, working quite closely with the World Health Organization, both in Geneva and the Africa Regional Office, AFRO, and also working quite closely with the Africa Union through the new body called Africa CDC that was created in 2017. And they just recently released their digital transformation strategy. So how does the digital health ecosystem look like in Africa? That's how it looks like. And they're not surprising. It's very fragmented. It's very similar to other continents where you've got, different systems, different verticals, working to solve problems. And there's very good evidence in terms of what the problems have been, and why this approach has been taken for a long time. Because then investment follows where the problem is greatest. So some of the greatest problems in Africa from a health perspective have been in communicable diseases such as HIV, and therefore you find a lot of the investment in digital health have gone towards building systems to support the HIV program. And we see the same thing in TB as well and others. But recently, I think as most of us know, we're seeing an emergence in non-communicable diseases. And hopefully as the world is tackling these disease challenges and health system challenges effectively, we are seeing a convergence in focusing at the individual, putting the individual at the center through the universal health coverage. So similarly in Africa, we are seeing a lot of that as well. Ministries of health are now, really trying to ensure there is a health systems wide look at things and strengthening the health systems broadly than through the vertical programs we are seeing in the past. And just like I mentioned, universal health coverage, we are seeing that now becoming a key pillar in terms of investments in healthcare. We're seeing programs such as PEPFAR that has supported very many African countries and made significant and really enormous, very admirable progress, really pivoting and starting to support the entire health system at large. And UHC obviously is a unifying sort of goal in terms of working towards that. So I wanted to start by showing how the ecosystem looks like. And I picked this because one, I'm from Kenya, so obviously I've got a bit of a bias towards what's going on in my country, but Kenya represents a lot of what's going on in other African countries, where we are seeing a lot of, we're seeing a lot of investments now going into health information exchange. And we know, like Dr. Alvin mentioned, OpenHI has done really significant work in many continents, popularizing the most, one of the easiest to understand framework for investing in a digital health enterprise, the OpenHI framework. And that has taken a lot of different shapes. In Kenya, this is how it looks like. So Ministry of Health and Government of Kenya broadly is looking at this and calling it a digital health superhighway, where there's a priority in the middle box there, where government has identified very clearly what is it responsible for as government. And those are the common services as we know them, the registries, such as the client registry, the shared health records, technology services and all that stuff. And we're seeing this trend becoming very popular in many countries where government is really, at last recognizing what they're really responsible for, or what at least they should invest in, and leave the entire of the ecosystem to sort of play out on its own. So I wanted to share this because this is one of the most recent initiatives in many African countries that we are seeing as representing the ecosystem currently in Africa. If you look at what's going on in Southern Africa, right from South Africa all the way up to North Africa, the tip of the continent, we're seeing a really admirable pivot towards digital health as an enterprise. And if you do some sort of a survey, you'll find schematics such as this, presented differently, but really highlighting that government really needs to invest in the infrastructure, and which is really at the core here. So just wanted to share this as one of the things that is happening.
Okay, thank you so much, Mr. Stephen Banyi. So I think next is our last speaker, Dr. Isabella Maina. Please welcome.
Yeah, okay. So thank you very much. Good evening from Kenya. Good morning, good afternoon from wherever you're listening from. My name is Isabella Maina. I'm a consultant working with WHO in a program called Health Data Collaborative, just to look at how we can scale up the HDC efforts in Africa, working with a colleague who was to present this, Pandula, who some of you may know, who is working in the Asian region. So I'll take us through a general presentation on Health Data Collaborative. We'll get to know what it is in a short while. And basically listening to the two presentations, basically on digital health information system, just to say that that is a great part of health information system. So basically what I'm going to present is really also linked to what has been presented earlier. So the first question would be, what is this Health Data Collaborative? So just to say, it is a UHC 2030 initiative that was established in 2016. And just as a reminder for all of us, we know that UHC 2030 is a global initiative to strengthen health system for countries to make progress towards universal health coverage, and basically to achieve the SDG goals. The Health Data Collaborative Platform has a secretariat that is hosted by WHO, but basically it is a platform that brings together different members from different organizations who belong to 7 different constituencies. So right now we have over 1,000 members, over 300 organizations, and all of these belong to 7 different constituencies as listed there. We have civil society, we have representation of countries like Kenya, we have donors, we have people who are working in philanthropy, we have bilateral and multilateral funding agencies, research, academia, and so forth. Then this platform, the members belong to several working groups. Basically, when you are a HDC member, you have a chance to work and contribute to HIS agenda through different working groups, and we shall see them. But as listed there, we have civil registration and vital statistics. We have community data working group. We have digital health governance, digital health and interoperability working group, GIS, logistic and management information working group, and routine health information system. Basically working group that look at the whole spectrum of health information system, so to speak. So what is the mission of this platform? From the presenters, especially the first presentation, we have seen a lot of fragmentation. If I remember that digital health ecosystem, the one you showed, you have so many players, all of them with different systems, all of them with different processes. So the Health Data Collaborative, this platform that brings together different members and different organizations, basically is to align the technical, financial support or financial resources towards common country plans for health information system or common country plans for health data, basically focusing on SDG targets and communities that are left behind. And when we talk of country health plans for data, you are looking at the whole spectrum or the whole process of data from data collection all the way to use, collection, storing, analyzing, using data to improve health outcomes. So basically, in a nutshell, it is a platform that brings together members who are drawn from different organizations who work through the technical working groups that I have mentioned before. And the sole mission is to align technical advocacy and financial resources towards country plans for health information system. And the idea is to get quality data to be able to track and improve the health outcomes, and more with a focus on SDGs and communities that are left behind. So to achieve that mission, the HDC has 3 objectives. And the first objective is capacity strengthening. Basically is to strengthen the country capacity on improving, strengthen the country capacity on improving, the whole process again of data from collection to use. The next objective is tied to the mission that I've talked about, aligning technical and financial resources. So the next objective is about efficiency and alignment, and basically is to improve efficiency and alignment of technical and financial investment in health data system. The next objective is to have data for action, and here is to increase the impact of global public goods. There are so many global public goods, especially in the space of health information system, that need to be contextualized to the country systems. And Health Data Collaborative does help in bringing that together. So the mission, aligning all partner stakeholders towards common health information plans for countries and working through this three objectives. We've already seen the constituencies. We said that we have the over 1,000 members, over 300 organizations who work through 7 constituencies, you know, the countries, private sector, civil society, academia, as we have seen. And the idea of having members from all these constituencies is to increase diversity of viewpoints, because we say that no man has a monopoly of ideas or information. So you want to bring information and technical support and also financial inputs from the different constituencies, and also looking at different geographical perspective. We have just been shown the example from Kenya, how Kenya is working on the digital superhighway. I know in the Asian region, others are working on different aspects, depending on the geography and also the context of the different countries. So the idea is to bring all this together to share different ideas for purposes of improving the health information systems in our respective countries. So we've already seen that the members work through different technical working groups. And in the first slide, I showed you the technical working groups. This is just a graphical representation of the technical working groups. Just to mention some of them: community data, digital health and interoperability, very key, especially towards the discussion that we are having here. We have civil registration and vital statistics, routine health information system, digital health and interoperability, and so forth. And the idea is that these technical working groups also produce global public goods, but also they have members who can offer technical support and also financial resources to the different countries, depending on priorities in each of the countries and the need. So the countries can use the HDC working group for technical support, depending on the needs. Just an example, for example, the last slide that was shown by the previous presenter, if Kenya was to request for support in terms of actualizing the digital superhighway, then we have this working group, the digital health and interoperability, that can come in handy to provide technical support should it be needed at the country office. Should Kenya then also be able, want to adopt norms and standards for interoperability, then the digital working group would be handy to help, and so forth, depending on the priorities for the different countries. We've already said that as we align the financial and technical resources, the focus is on SDGs and communities left behind. We've seen that HDC is a UHC 2030 initiative, and we have said that the UHC 2030 initiative is basically an initiative to improve health systems towards making progress for SDGs. The HDC is also related to SDG 3 Global Action Plan for Data and Digital Accelerator. We already know that to make progress towards achieving the SDG, there's this Global Action Plan that has several dimensions. For example, PHC, social determinants of health, determinants of health, and so forth. And one of the dimension, the key dimension that concerns us as people, practitioners of health information system, is data and digital accelerator. So HDC is highly related to this digital data and digital accelerator. And the idea is to have coordinated approach using health data for health impact, with a focus on SDGs again and communities that are left behind. So the idea is to work together through all the initiatives that exist, be it globally, be it from the regions, and also be it from the country level. At the global level, these initiatives are also already working together. We've already seen that partners already are working together, also at the global level, regional level, and also at the country level. So as we work towards HDC, one of the key areas is partner alignment and collaboration, as we have seen from the mission. And what we are promoting is to have better partner harmonization and alignment around all the systems of health information system, or all the dimensions of health information system as outlined by SCORE. Just to say that SCORE is one of the data technical package developed by WHO that sort of brings all the elements of health information system together, just to help countries look at the strengths and also weaknesses and gaps in terms of health information system. And SCORE just means, for example, the S means the issues of surveys, whether a country is conducting regular population-based health surveys, issues of surveillance, issues of censuses, for example, population census, and so forth. C in SCORE means counting births, deaths, and causes of death. And we do know that in most of our countries, the issues of counting births, deaths, and causes of death is something that is left behind. For example, in Africa, only 40% of births are registered, while only 10% of deaths are registered. And this varies from country to country. In terms of O, it is optimizing health service data, for example, routine reporting system with patient monitoring, regular system to monitor service availability, and so forth. The R is basically about reviewing progress and performance, while E is enabling data use for policy and action. So in terms of partner alignment, HDC is promoting alignment around these dimensions of health information system. So what we are doing as HDC Secretariat is to help countries or to work with countries to look at where partners or stakeholders are supporting countries around those dimensions. The SCORE further goes to define, to sort of show performance of the different aspects of the health information systems using different keys. For example, if you look at Bangladesh up there, where my cursor is, SCORE S, which is for survey, is light green in color. This means that that system of surveys in Bangladesh is well developed. In terms of counting births and deaths and causes of death data, which is C, it is about orange or brown in color. That means that it has limited capacity. So it means that in Bangladesh, there's need to focus on, counting births and deaths. If it's optimizing data, it is light green, so some well-developed capacity, and deep green in terms of review, it is a higher capacity. So the interpretation is that way. But why we are showing this is to show where different partners are working to support the different countries in the various dimensions of health information system. This information that is displayed here is based on desk review from existing documents online, based on country, partner compacts. For example, if there's a compact that is available from GIZ for different countries, then we are able to see where GIZ is supporting the different countries in all these dimensions for the SCORE areas that I had shown. So basically what is displayed here is based on desk review, but the idea is to do an in-depth mapping to see which partner is supporting which aspects of health information system. And the purpose of this is to ensure that we are more efficient in terms of supporting with avoidance of duplication. So this is work in progress. This is based on desk review. It is not complete, but will be completed as we engage the countries. This is a scenario for the Africa region. What I was displaying there is for Asia. Just maybe to give an example, if you look, for example, Kenya, and look at World Health Organization, they support in terms of optimizing data. They support in terms of reviewing and performance. And also they support, also if you go to the next country and so forth. If you look at USAID, they support in terms of optimizing data and so forth. And this again is based on desk review, based on existing information, but at the country level, we hope to do in-depth mapping of resources and also partner support. And as I say, the idea is to avoid duplication. Basically, what was being shown in the presentation, one, we want harmonization and so forth. Now, since inception in 2016, because HDC was initiated in 2016, we have about 8 countries that have adopted the approach, and all of them have registered different levels of success, different levels of impact, but the key measure of success is that alignment of partner support. In some countries, we have a harmonized health information system, reduction in terms of burden of reporting. For example, the reporting tools. Others have harmonized health facility assessment. For example, in Kenya, we have the harmonized health facility assessment, bringing together different assessments. For example, the SARA, the SDI, Service Delivery Indicator Survey, and so many other surveys, data quality review survey, into one survey, so that there's a reduction of duplication and for more efficiencies. Other impacts have been joint country missions that brings together different partners, going to a mission to different countries to just look at the status of health information system, and also agreeing on an action plan to support the countries. For example, there was one recently on CRVS that was done in Nepal and Malawi, and one for Pakistan that will be happening. Then alignment of country needs with partner resources. Basically, we have examples, for example, from Botswana, where all partners have aligned based on the country plans, in Cameroon, and so forth. Then health data capacity development. The second presenter talked about how we develop capacity for health information system. And we have seen many other countries through HDC approach, improving capacity for data in their respective countries. For example, Kenya, also reducing the burden of data collection and improved quality of reporting. And we have examples, for example, from Malawi. And we do know that in various countries, we have this burden of so many indicators, so many reporting forms, so many partners requiring different reports. And through this DHDC approach, there has been some sort of alignment with some reprieve for countries in terms of reduction of the burden for data collection and also reporting. So that partners then use common reports instead of having parallel reports to each of the partners. Then there has been success in terms of initiatives towards co-investment from partners. For example, digital health investments roadmap in Tanzania, where partners are coming together to invest in a common roadmap and common priorities for improving the digital health ecosystem in the country. Then also generating dialogue and opportunities for partnership, where we have seen improvement in terms of coordination for health information system in the countries, where we have working groups, stakeholders, representative groups. For example, at the global level, we have hub and spoke initiatives, we have bilateral meetings, but also at the country level, so many countries have established or strengthened their coordination mechanisms for health information system. Just to give an example, for example, in Botswana, they established what they call technical working groups and steering group to improve health information system, or to coordinate better in terms of priorities that they are implementing at the country level. And others have strengthened the existing partnership framework through the HDC approach. This is just to cite a few examples. Others have established data warehouses and so forth. For example, Botswana, others are in the process of establishing health observatory. Malawi is one, just to maybe align with what is in discussion today on digital health system. So HDC then does offer us an opportunity to work together also with the team that is here. And the idea is to have a country initiated process so that the approach is more sustainable at the country level. It is through a bottom-up approach where the country takes lead. So in case a country wants to be engaged, the first step is a country makes requests. We have a standard form for expression of interest that we'll be sharing with countries to make requests. And then apart from a country making requests, there are other opportunities that present themselves. For example, in such a platform, you may discover an opportunity that would help us align in a certain country. Just the example I gave of the harmonized health facility assessment, should maybe partners here or partners elsewhere see the need to do that in a certain country, then that opportunity can be sold to the country to adopt. The next step is then deliberations through the working groups for technical and financial support, depending on the country priorities, and then mobilization of resources. And we do know that there are a lot of resources at the country level. The idea is how efficient those resources are used, or how aligned they are to the country plans. So mobilization, but also alignment of resources at the country level. Then country engagement through a coordinated approach and coordination by the country team. So we are encouraging all members or participants here also to join us in the HDC so that we work together even as we engage countries to scale up the HDC efforts from the current 8 countries to around maybe 20-something by next year. So kindly visit us through the HDC platform or the website through that link that is there. We'll share the presentation, and also you can email us for further information. There's a lot of material that is available online on the countries that have engaged before, the impact and so forth, and more details on what HDC is. Thank you very much for invitation, and look forward to further engagements and discussions.
Thank you, Dr.
Thank
Isabella. Thank you very much. I think we've reached the top of the hour, and there was a question actually in the Q&A box, and responses were being typed by Dr. Chaminda and myself. But if there are any other questions, you can put it in the chat box. Charisse already posted how to join AHIN. So please join us if you're not yet in the mailing list. There's no registration fee. We just ask you to share with us your curriculum vitae. So there's a question from Dr. Thep from Laos. Thank you for very nice presentations. Question to Isabella. How about counting childbirth and death in Kenya? And how about the CRVS? Are there any interoperability with the other healthcare systems, Isabella?
So thank you very much. So just like any other low and middle income countries, we are still struggling with counting birth and death. But I would say we are above the average of 40%. The births quite have improved right recently. We are in over 70%. But basically it's because of the requirement by government that when a child is joining school, they require a birth certificate. There's also spirited efforts to ensure that the services are taken closer to the people. The death registration is still wanting. I think we are at around in the 40s. But the country is now working to ensure that the interoperability of all systems, as shown by the second presenter. That was the superhighway that is bringing all systems together. Thank you.
Thank you, Isabella. Thank you, Dr. Tep. Any more questions? If none, I know that it's the top of the hour. Thank you very much for joining the first Africa-Asia Digital Health Knowledge Exchange. I hope we can have you again in the next exchange. We will talk about more complex topics like repositories and health information exchanges. And with that, I'd like to greet everyone good night and thank you.